Hi everyone, we're here for the second section of the neuro chapter, chapter 28, and we're going to start with brachial palsy. So brachial palsy is a stretch injury that can happen in babies as they're navigating through the vaginal canal. It can be seen following C-sections, but is not as common. It impacts the cervical nerve roots, the upper being C5 and C6 for Erb palsy, and C7 and C8 and T1 for Klumpke palsy. And the injury occurs based on the traction that was involved with the nerve during delivery. Some risk factors in the neonate that may indicate a plexus injury include a high birth weight, shoulder dystocia, a lengthy labor, breech presentation, if mom had gestational diabetes, or if forceps or vacuum extraction was utilized. Some clinical findings that you may see on exam for Erb palsy is the positioning of the arm, such as a waiter's tip. For Klumpke palsy, you may notice a paralyzed hand and forearm, even though there may be good shoulder and elbow function. And if there's concern for a total plexus avulsion, then that's a completely flaccid arm. Your exam is going to be detailed and include reflexes, such as the Moro reflex to assess symmetry. You want to check their respirations. You want to see if there's evidence of Horner syndrome, which has to do with pupillary contraction. You're looking for anhidrosis, which is the lack of sweat, and you want to do a neuromuscular assessment based on the involved extremity. Some diagnostic studies that may be considered would be a CT, MRI, and possibly an EMG if nerve root avulsion is suspected. Some differential diagnoses will include ipsilateral clavicle fracture or Horner syndrome. Management would include gentle range of motion, and these can be done by parents at home with follow-up appointments by the PCP to assess, and there also may be the need for referral to physical therapy. There may be the need for surgical intervention if there is a nerve root avulsion. The majority of these palsies resolve between 80 and 95% spontaneously over several weeks to several months, unless there is the nerve root avulsion. Next, let's talk about Guillain-Barré syndrome. This is an immune-mediated syndrome that impacts the peripheral nerves and is noted to have progressive weakness and diminished or absent reflexes. It is usually seen after a respiratory or a GI viral infection. Most of the cases have acute demyelinating neuropathy. And on your clinical findings, you're going to do a detailed history. You want to know if there's been any nonspecific viral infections. You're assessing for weakness or any neurological changes in sensory, motor, the visual systems, and was the onset gradual. You're also wanting to assess to see if there's been any fevers. On physical exam, you may note tenderness or pain in the muscles. The little one may be irritable, have difficulty walking. There may be paresthesia. There may be respiratory insufficiency. There may be some facial weakness and difficulty swallowing. You're wanting to assess for any signs of viral meningitis, if there's been any urinary retention or incontinence, and assessing for any blood pressure or heart rate changes. Diagnostic studies that you may consider would be a spinal tap for cerebral spinal fluid. It is likely negative for blood. Back up on that, I'm sorry. Blood cultures are usually negative, and they would definitely be inconclusive for viral cultures. You may notice a normal or mildly elevated creatinine kinase. If you're completing nerve conduction studies, you may note that those may be decreased, and an EMG may show denervation of the muscle. Differential diagnoses may include encephalitis, meningitis, atrophy to the spinal muscle, HIV, metabolic diseases, and the West Nile virus. There is a good table in your book, box 28-4, which is the most common types of, actually disregard that, I'm sorry. Management would be hospitalization to observe. They may require IVIG. If not responsive to this, then there may be plasmapheresis and supportive care. Complications that are going to impact the Guillain-Barré syndrome are going to be any chronic illnesses that the child may have. You may see relapses occur in children, and there may be unresolved weakness. Next, we're going to move on to headaches. And these can be common during childhood and can increase in adolescence. They're one of the most common reasons for parents to seek medical care for their kids. They can be divided into two classifications, acute and chronic. And box 28-4 does a great job on breaking down the most common types of primary headaches seen in the office setting. It's divided down into pediatric migraine, infrequent tension type headaches, and then chronic tension type headaches. So review that. With all of our conditions, we want to get a thorough history. You're wanting to learn more about duration, frequency, what might trigger the headaches, where it's located on the head, the quality and the severity of the pain. You want to know at what age did the headache start for the child, if anything done at home has helped, if any medications from home have helped. Does the child have any associated symptoms, whether there's nausea or vomiting, whether there's change in vision, things such as that? Has there been any head trauma? Are there any psychological symptoms, and any family history of migraines? It's important to be able to distinguish on the different features of each headache type. You can have migraines and migraines with an aura. And auras are typically visual changes where you may see sparkling lights or colored lines. You may see things that are not there. Some individuals can have some temporary blindness. They may have blurred vision. Migraines can be associated with nausea, abdominal pain, vomiting. There may be unilateral pain, pulsating, sharp pain. Some individuals gain relief by sleeping. So look in your book for more details on that, and then table 28-6 kind of pulls that together. There is a migraine called an abdominal migraine, which is more rare, and it may include midline pain, nausea, and vomiting, and you may or may not have a headache. The headache may be minimal. These symptoms are often suggestive of a complex partial seizure. Then there's also your tension headaches, which are more muscle contractions. The pain can be dull. It may be bifrontal or occipital, and you may have nausea or vomiting only occurring rarely. There's not a precursor to this or a prodrome. Tension headaches can last for several days or weeks, but generally do not interfere with day-to-day activities. Secondary headaches, or ones that have a pathological process, they have a sudden onset. They can be hyperacute or noted to have increasing pain or other neurological signs. These can require prompt referral. Some red flags. The red flags can be found in box 28-5, and so for infants, that could be a full anterior fontanelle. They could have open suture lines, an impaired upward gaze, a shrill cry, lethargy, vomiting. And in kids, the headache could be described as severe, excruciating. They could have papilledema or unusual eye movement. They could have an unsteady gait, hemiparesis, abnormal deep tendon reflexes. There could be personality changes, and those are all indicative of a prompt referral. With secondary migraines, they can be worse in the morning or upon awakening. It can waken the child from sleep. It may not have any nausea, but you may have vomiting. There can be the neck pain or the back of the head pain. There could be seizures, unsteady gait. You can have changes in behavior. There can be fever. It's important to assess for any family history of neurological disorders. And these headaches may be seen in kids with a VP shunt or any hydrocephalitis. On physical exam, you're going to want to try to check blood pressure, both supine and standing. Make sure the child is growing appropriately. You want to do an extensive head, ears, eyes, nose, and throat. You're checking the eyes, the ears, the neck, the sinuses, the teeth, and the TMJ. You want to assess the thyroid gland. You also want to palpate and assess the bones and the muscles of the skull, assess extremities, and look at the functioning of the nerves and reflexes. Diagnostic studies would only be done if indicated. Some of your differential diagnoses might include a sinusitis, an intracranial mass, a pseudotumor cerebri, sleep disorders, hypothyroidism, hypertension, and cyclic vomiting. Management is going to be stress and pain management. And with migraines, as in adults, abortive therapy is the most important thing, trying to head them off before they get to this point. Your goal is trying to reduce the frequency, the severity, and the length of treatment. Next, let's talk about head injuries, and these are referred to as traumatic brain injuries or TBIs. They can be mild to severe in the damage that's done to the tissue. Most of these occur secondary to an acceleration, deacceleration force or rotational force, and there can be a long-term sequence of events that are more likely in children with developing brains. So if you've had an open trauma, you might see more focal injuries. A closed trauma may have more diffuse damage. Some secondary effects may include hypoxia, ischemia, hypotension, and hemorrhage. Secondary effects to the trauma, are the hypoxemia and the ischemia. We know that traumatic brain injuries is the most common cause of trauma in pediatrics and results in about 2,000 deaths annually, greater than 35,000 hospitalizations, and greater than 400,000 emergency room visits annually for children 0 to 14. On table 29-11, let's update that since the chapter has changed to table 28-11. There's characteristics of head injuries based on key characteristics. I encourage you to look at that. When you're doing your assessment, you want to get a good history, and so you're going to want to use the Acute Concussion Evaluation Tool, the ACE tool, and it can be found at the CDC website. You're wanting to know if there's been any history of an injury that might have involved a fall and the height that the fall came from. You are assessing for any loss or alteration of consciousness, any confusion, irritability, change in behavior. You want to know if there's been any vomiting by the child and what the frequency of that is. Has the child had complaints of a headache? Has there been any blurred vision or double vision? And is the child complaining of any numbness or loss of sensation to arms or legs? Also assessing if there's been any loss of balance or any difficulty with walking. Your clinical findings on a physical exam, you want to assess their vital signs. We know that changes in vital signs can often indicate shock or intracranial hypertension. You want to do a thorough physical exam, also including a detailed oral exam. And you want to do a careful neurological exam, including assessing for level of consciousness, mental status, motor functions of both gross and fine motor. You want to assess for sensory function, cranial nerve functioning, and assess the reflexes. You're looking for any signs of CNS involvement. And you're also going to want to be evaluating their mental status by using the Glasgow Coma Scale. And if you're not familiar with that, that's in the chapter, table 28-12. Then another physical symptom that you may be looking for is periorbital hemorrhage, which is called the raccoon eyes. And also then ecchymosis behind the ears, which is called battle signs. And this is when blood has seeped out from their head trauma. Other clinical findings, diagnostic studies is going to be based on the severity of the symptoms, but CT would be required for any of the following: if there was a penetrating trauma, if the child had altered level of consciousness, amnesia, if there was any focal neurological signs or deficits, if there was a depressed skull fracture or a basilar injury, seizures, persistent vomiting, or if there's been any history of coagulopathy, as there would be concern for an intracranial bleed. Your differential diagnosis could be wide based on whether it's a minor injury or an extensive injury. Your management is going to be based on the level of involvement. If it's a minor closed head injury, no loss of consciousness, you may observe in the clinic, in an ER, or at home, and provide the parent or the guardian with signs and symptoms to watch for, what to call for, and what to return to the ER for. Management for the child who has had the minor closed head injury and a brief loss of consciousness. That can be observation in the clinic, in the ER, or at home, understanding what to look for. There may be CT scanning to assess for any type of bleed, and hospitalization if the home environment is not considered to be reliable monitoring. So for the child that's had a moderate head injury and let me go to the next slide. A moderate head injury and has worrisome symptoms that may require an admission or at least a prolonged observation in the ED. Things that you would hospitalize for would be changing vital signs if there were seizures, altered mental status, or slurred speech, prolonged unconsciousness or persistent memory issues, depressed or basilar skull fractures, persistent headaches, reoccurring vomiting, unexplained fevers, any unexplained injuries, especially if there's concerns for child abuse, and then if there's worrisome MRI or CT findings. Complications of a head injury can include concussions, post-traumatic seizures, cerebral contusions, epidural, subdural, intracerebral hematoma, subarachnoid hemorrhage, acute brain swelling. This increased intracranial lesions can be life-threatening. And then the post-trauma sequelae and post-concussion syndrome can occur where you can have cognitive deficits that can persist for months. There can be speech and motor difficulties for years. And in a post-concussion syndrome, very common symptoms include headaches, dizziness, irritability, impaired concentration, aggression, disobedience, irritation, and anxiety in younger kids. We know that if we're sending these patients and parents home, they need to have lots of education. There needs to be written educational materials, as we talked about earlier, indications for an emergency department evaluation, care for the first 24 hours, what to look for neurologically. Then also it's important for prevention, giving information on the importance of helmets with bikes, skateboards, scooters, motorcycles, and in sports, protecting from falls on playgrounds, and then appropriate seat restraints in motor vehicles. Let's talk for a moment about disturbances of head growth, and the first thing that we'll talk about is macrocephaly, which is a head circumference greater than 2 standard deviations above the mean, and you might see this with hydrocephaly, with megalencephaly, subdural hematoma, a tumor, or skull thickening. So microcephaly is a head circumference that's 2 standard deviations below the mean. The head can be normal shape, but it may have overlapping sutures. There can be delayed development and neurological problems. Another condition is called, let me go back to microcephaly here for just a moment. It can result from conditions in the brain which didn't allow the brain to form correctly, whether that's from genetic or chromosomal abnormalities. And it's important to know that brain damage that occurs prenatally may or may not always be seen initially on the newborn, and if there's a decreasing or a plateauing head circumference, you may see that around the age of 3 to 6 months. These kids can have delayed developmental milestones and neurological problems, and management of this condition is supportive and would require the assistance of an interdisciplinary team to get the proper resources out. But important is keeping them well, having good nutrition, because if it's a malnutrition concern, this can be a treatable cause for microcephaly. And then of course referring to a neurologist for diagnostic purposes. Okay, so now the next thing we'll talk about is craniosynostosis. Sorry if I butchered that. But it is due to primary and secondary causes. So a congenital would be considered a primary cause, and this is the early closure or the absence of one or more cranial sutures. There is a type called the syndromic craniosynostosis, and this can account for about 25% of all cases, and it's associated with over 180 familial syndromes. So what we see with this is growth along the remaining open suture line produces a skull deformity. Because of the altered shape of the skull, there can be increased intracranial pressure as the brain tries to grow within the confined space. But that is not always the case. On physical exam, you're going to be looking for cranial symmetry for the first year, and then also noting symmetry of neck rotation. For the cranial symmetry, the best way to do this is looking from the top of the head down, and you're noting the position of the ears and the cheekbones. There's some more details of this in the book. I would encourage you to look at figure 28-4, which gives some different characteristics of skull deformities seen with this condition. So a CT scan of the head is standard for a skull-shaped deformity. Often, though, it doesn't require imaging when the history and physical exam are diagnostic, and if necessary, if there's neurological concerns, an MRI can be done. Differential diagnoses can include normal frontal metopic suture prominence. This prominence may not be clinically significant, and it doesn't signify craniosynostosis and doesn't require any interventions. But if your child that you're examining has this condition, then you would be referring for management to a neurosurgeon. It's also important that the primary care provider help educate the parent if there's an anticipated concern ahead of time. Let's next talk about some CNS infections. And these can be bacterial, virus, fungi, sporocytes, protozoa, parasites. Clinical findings, a good history. Has there been any recent upper respiratory or GI symptoms with fever? Has there been any increasing lethargy or irritability? Any recent head injury or surgery? And are we working with any immunodeficiency diseases? Clinical findings on exam may include systemic signs such as fever or malaise. CNS signs may include headaches, stiff neck, stiff spine, nausea, vomiting, and change in mental status. There can be fever or hypothermia. You may see some deficits in cranial nerves. There may be the presence of Kernig or Brudzinski sign for meningeal irritation. You may see bulging fontanelles. There may be papilledema. There could be cranial nerve palsies, and findings can differ depending on the age. Diagnostic studies would include blood culture, CBC, UA chemistries, and a lumbar puncture. Management includes a referral as soon as possible if there is concerns for CNS infection. You're going to note a more aggressive management if their little one is hypovolemic, if there's hypoglycemia, hyponatremia, acidosis, shock, or if there's increased intracranial pressure. It's important after resolution of the infection that the child have an auditory evaluation because hearing loss can occur in all forms of meningitis. Also, blindness, hydrocephaly, cerebral palsy, developmental delays may occur with this condition. Let's talk a little bit about a hypotonic infant, also referred to as a floppy infant, who droops when they're picked up. This child may be alert but have depressed spontaneous movements. They may have had abnormal movement in utero. You also may see these little ones with issues with seizures, abnormal pain responses, muscle wasting, absent reflexes. Etiologies are usually based on metabolic or CNS dysfunction, and if CNS is involved, then it's typically pretty serious, and these would be cases that you would refer to a specialist and also a geneticist. Next is Reye syndrome, which is encephalopathy often associated with a virus, and infrequently these cases are seen with varicella or non-specific respiratory infections, specifically H. influenza type B. Some symptoms you may see would include severe vomiting. Sorry that there needs to be an E there, which progresses to some irrational behavior. You may go into a coma. There may be apnea, fixed pupils, decorticate posturing, and this would require an immediate referral to at the caudal end, which allows for freedom of movement during growth and activities. With a tethered cord, though, it's more fixed and rope-like at the junction of L2. This can cause abnormal stretching and some damage to nerve cells, fibers, and even some blood vessels. You may note neurological deterioration with this condition. It can be associated with a congenital spinal anomaly. 90% can be spina bifida. But it can also be the result of some bony protrusions, some tough membrane bands, lipomas, tumors, cysts, or trauma in the caudal equina area. And to diagnose this, you would do an MRI of the spine. Next, let's talk about some malformations, and one that is you may have heard of is the Arnold Chiari malformation. There's a couple of different types, and these are congenital spinal cord anomalies whose sequelae may not be evident until late in childhood, even into adulthood. Type 1 malformations involve the downward elongation or herniation of the caudal end of the cerebellar vermis into the foramen magnum. And then type 2 is a herniation that can lead to brainstem and upper cervical cord compression and necrosis. Diagnosis is made by MRI. It's important to note that these are kids that you would not do or order a lumbar puncture on, as it could risk causing a brainstem herniation. Okay, let's talk about myelomeningioceles briefly. This is a failure during embryogenesis of the vertebra, the skull, the meninges, the brain, and or the spinal column to become encapsulated by the lamina of the vertebrae. In essence, the tube doesn't close, and the vertebral column do not close as they should. It refers to the protrusion of both the spinal cord, the nerve roots, and the layers of the meninges through a spinal deficit. So one type might be spina bifida cystica, which is your myelomeningeocele, and then there's spina bifida occulta, which there's no herniation, but you have an open column. On clinical findings, you may see that these little ones have, there's been poor intake of folic acid during pregnancy. You've all heard of encouraging your pregnant moms to increase their folic acid intake, and that's to help prevent these conditions. You may see a sac-like cyst that contains spinal fluid. There may be flaccid paralysis of the lower extremities. There could be absence of deep tendon reflexes, a lack of pain or touch responses, and there can also be constant urinary dribbling. So for management, come on computer, management of these symptoms, you're going to want to do a serial cranial ultrasound to monitor for any hydrocephaly. You're going to maybe see a surgical resection or closure of the structures at birth. And care of these little ones is multidisciplinary to offer support. And then there's going to be GU management. Prognosis for normal intelligence is approximately 70%. Functional mobility will depend on the level and the degree of involvement. And as we talked about, prevention, so encouraging all females of childbearing age to take a folic acid supplement. Alright, so let's talk about myasthenia gravis, which is an autoimmune disorder that produces immune-mediated neuromuscular blockades. It originates when these circulating receptor binding antibodies decrease the number of available acetylcholine receptors, which leaves the nerves less responsive than normal. On physical exam, you may notice extraocular muscle weakness. You may notice drooping of the eyelids, dysphagia, muscle weakness of the neck flexors, and there may be rapid muscle fatigue noted. When trying to diagnose this, diagnostics